Here we go. Thanks very much for inviting me to talk to you. Some of you might already know me. I've spent the last 4 days here during the pre-conference sessions and was teaching some of you in the operating theatre. I was actually quite humbled because I realized that you do the amount of cases that we do in about 2 months, and that the echo equipment I worked with was actually more updated than ours. So in a way, I feel I should be sitting there listening to one of you guys telling me about your experience. But I hope that I still add a little bit of value to the session. So my job is just to tell you about a few clinical cases and apply the knowledge we just acquired from a previous speaker about the assessment of the aortic valve, both in regurgitation and stenosis. So this is our first case. It was a 45-year-old patient with a short history of feeling unwell, increasingly short of breath and lethargy. He was admitted in a small district hospital with signs of infection and sepsis and pulmonary edema on the X-ray. They did an echo, transthoracic, showed severe AR with a mobile vegetation, and sent him to us for evaluation for aortic valve surgery. We tend to administer antibiotics for about 5 to 6 weeks in patients who are hemodynamically stable before we take them to theatre to reduce the chance of infection of the new bioprosthesis. So we tried to do that. However, the patient deteriorated after 3 weeks acutely and went into heart failure and showed ECG changes and troponin rises, and the idea was that possibly the patient suffered an embolic infarct from the vegetation into the right coronary artery. This now facilitated surgery at a much more rapid rate, so the patient was rushed to theatre, and we started doing a TOE intraoperatively. So we're starting with a 4-chamber view. Put some color on, and we see a couple of problems already. So we obviously have a diseased valve with endocarditis, so we're not surprised to see aortic regurgitation. It's a little bit eccentric there, but probably about 50% of the LVOT is filled. But we also see a small jet arising from the anterior mitral valve leaflet, which is not from the commissure, but from the body of the leaflet, which was a small perforation in the anterior mitral valve leaflet, which had to be addressed as well. And we zoom in a little bit to give you a better view. And again, you can see that the LVOT is filled by about 50%, which will put this aortic regurgitation into a moderate area. More than 60% would be severe. And you can see the origin of the jet in the anterior mitral valve leaflet. And we're moving on to a short axis view of the aorta. And you can see this leaflet is not normal. It's a bicuspid leaflet. And the left and right coronary cusp are fused. So we have a vegetation on the sort of non-coronary cusp side of the valve that's flipping in and out. And we have an elliptic opening of the valve in systole. This is just a X-plane view of this. It's quite useful, I think. It also saves a lot of time. You don't have to do sequential views. You can just click X-plane. You take a 90-degree view of the original view, and you save yourself a lot of time. And it gives you a better idea of the three-dimensional structures if you don't have 3D echo. Then we've moved into the stomach. This is a deep transgastric view. And we take a continuous wave Doppler signal through the valve to see whether there's any stenosis. And we see a maximum pressure gradient of 12 and a mean gradient of 7, which is normal, so the valve was not stenotic, it was purely regurgitant. We then moved the baseline down to look at the regurgitant flow, and again put a continuous wave Doppler through and look at the slope of the pressure decay and measure this slope. The pressure half-time in this case was 87 milliseconds. The cutoff to call it severe is usually 200 milliseconds, 220 milliseconds. So that would put it into the severe aortic regurgitant category. And then this is just a slightly different scale of the same picture. You see the inflow and the outflow and the regurgitation in the same slide. Then we assess the LV function. So this ventricle doesn't look all too happy, not surprisingly, and it's a bit dilated. We do some M-mode measurements, even though we've talked about that before. It is not recommended anymore to have this as an absolute qualification of ejection fraction, but as a screening method, it's still reasonably okay. So we're getting about 40% ejection fraction, and the end diastolic diameter is 6.45 centimeter, which is significantly dilated. We do a TAPSI on the RV because we're concerned about the RV having suffered an infarction, and the TAPSI is only 0.9 centimeters, which is severely impaired. Then we move into the descending aorta and look for aortic flow reversal in diastole by placing a pulse wave Doppler into the distal part of the descending aorta, and we see systolic forward flow and complete holosystolic flow reversal more than 20 meters per second by a long way. So this also puts it into severe aortic regurgitation territory. Oops, sorry. And then we obviously need to do some measurements to give our surgeon an idea what sort of valve he needs to use, and the sizes of the LVOT as discussed before. So just a quick overview of the severity or the assessment of severity of AR. So the main values we use are the first four. The most useful ones is probably vena contractor. Anything more than 6 millimeters is severe. The jet width to LVOT ratio, also called Perry index, where more than 65% is severe. The pressure half time by continuous wave Doppler, where less than 200 milliseconds is severe, and flow reversal in descending aorta, which makes it severe if it's holodiastolic and more than 20 centimeters per second. The rest is probably not that practical in our routine practice. This is just a new guideline by the ESC from, I believe this year, decision-making tree as to whether or not you should operate on somebody or whether or not you should observe. You can probably look into that in more detail. If you look at their website, it's freely available for everybody. Our next case, then this case obviously is just to sum up the findings: bicuspid aortic valve, infective endocarditis with a large mobile mass on the non-coronary cusp, severe aortic regurgitation with a pressure half time of 87 milliseconds, holodiastolic flow reversal in descending aorta, and the perforation of the anterior mitral valve leaflet with a moderately impaired LV, impaired RV. So what did we do? We put a 25 millimeter bioprosthesis in. We plagiated the perforation and repaired it. And we prepared the patient for ECMO just in case we couldn't come off bypass because of RV failure. And this was post-op. So the valve is in situ. You see the ring of the annulus of the valve, giving you an echo shadow dropout below the valve. So acoustic shadowing, as discussed before. You see the leaflets opening very well and separating nicely. It's not rocking, it's sitting stable. Put some color on, you look for regurgitation, especially around the annulus, as it should be competent being a bioprosthetic valve. And there is no paravalvular leak visible, and you can see that the perforation in the mitral valve has disappeared. We go deep transgastric, another look at regurgitation as you're now in line with the flow as compared to perpendicular. You get a better idea. Again, there is no regurgitation, and we take a gradient, and the mean gradient is 8 millimeters of mercury, which is perfect. As Kieran already said, you can put an MO Doppler through the leaflets of the bioprosthetic valve as well, and you can measure the separation. There should be more than 15 millimeters in an adult prosthesis, and it's 2 centimeters in this case. And I have a short axis view. You see the 3 support struts and the valve opening very nicely. You can do a planimetry. It's probably not the most accurate way, but it's possible. And then we had a look at the short axis view again, transgastric, at the LV and the RV. The RV had picked up. We didn't need to go on ECMO, and we could take the patient to ICU and inotropic support. His ejection fraction had improved to 50%, and his end-diastolic diameter has reduced slightly to 6 centimeters, which is still dilated. And the flow in the descending aorta is not reversed in diastole anymore. You just have systolic forward flow. Systolic forward flow, and diastole is no flow. So just a little bit about bicuspid valves is one of the most common congenital malformations of valves. The incidence is about 2% in the general population, and it is due to a fibrillin-1 deficiency, which is a general problem for connective tissues, in particular the ascending and descending thoracic aorta. So you must always check for abnormalities of those two structures. In systole, there's two cusps with an elliptical opening. In diastole, it can very easily be taken as a tricuspid valve because quite often there is a raphe, and it looks like there is a third commissure, which then disappears when the valve opens. So always look at it in systole. The most common one is the fusion of the left and the right coronary cusp. The next one is between the non and the right coronary cusp. 50% of them have a dilated thoracic aorta, so check that out. And it's quite often connected to other congenital defects like coarctation, VSD, ASD, and PDAs. So these also have to be ruled out to make sure this is not a single pathology, but part of a more broader problem. And it accounts to about 50% of our patients who come in with aortic stenosis for AVR. So the bicuspid aortic valve, as seen here, with a non-coronary cusp and a fused left to right coronary cusp, and the less common one with a fused non and right coronary cusp and a smaller left coronary cusp. They don't necessarily have to cause central AR. This was quite eccentric. Doesn't look particularly dramatic. Peri-index is probably 25%. But if you go in the descending aorta, you see again a holodiastolic flow reversal. This looks upside down because my colleague who took this image put the pulse wave Doppler into the proximal part of the aorta on this image, so he looks at flow coming towards you rather than away from you. The next case, we have a TAVI lab. Every now and then they run into trouble and we get involved. This was a patient who was a Jehovah's Witness, decided to go for TAVI to reduce the risk of blood transfusion, and had an Edwards valve inserted. Something went wrong. It was deployed prematurely. It flipped into the LVT and into the LV and caused problems. So let's see how that looks like. Now this is the long axis view, mid-esophageal long axis view with the LVUT blocked by the valve that was deployed prematurely and has wedged itself sideways into the LVUT. If you look at this with color flow, you see it causes massive overload of the LV with severe mitral regurgitation. It blocks the LVUT and it leads to aortic regurgitation. This is a little bit later, and some of you with keen eyes will see that there's smoke now in the left atrium, indicating extremely low flow. This patient was now peri-arrest, and our friendly cardiac surgeon was asked to rescue the situation. In the meantime, they put the introducer through the LVUT and pushed the valve back into the LV in order to free the LVUT up and stop the patient from arresting. And you see that there with the introducer coming in here, and the valve is sort of dancing around. In that situation, we took the patient to the operating theater and put a new valve in. And this is the X-plane view post-operatively, just to look for paravalvular leaks. And there, again, was none. We talked a little bit of rheumatic disease in the previous talk, so it affects primarily the edges of the valve, not the body of the valve. So the edges become thickened, they don't coap properly, and it typically produces a triangular defect in the center, which leads to central aortic regurgitation in a triangular pattern. Very classic. That's just zoomed in. This is another case. The aortic valve was not directly pathologic, but it was affected by an aortic dissection. Not sure why this wasn't running. If you put color on, you see the aortic regurgitation, quite eccentric again. You see the dissection flap flipping around. And you see turbulent flow coming out of the aortic valve and a dilated aortic root. Sorry. This is quite important. So we took some measurements. This is why it's crucial to do that. And the problem was, even though we saw AR and this valve was not affected by the flap as such, but probably had an intrinsic problem, the diameter of the LVT was only 1.6 centimeters. The smallest prosthesis we have is 19 millimeters. So this patient was actually not a good candidate for an AVR unless you want to expand the root. So that's an important finding that might guide the surgeon in his proceedings. That's a short axis view of the aortic valve, and you see the dissection flap in the non-coronary cusp area in the sinus of Valsalva. Put color on, and you see the main leakage comes from the junction between the left and the right coronary cusp. This is the ascending aorta with a big dissection flap, quite a prominent pulmonary artery, and you might remember something from the first images. There could be something else happening. This is a short axis view of the descending aorta with a dissection flap in the middle. This is a long axis view, and again, you see a dissection flap starting here. We put some pulse wave Doppler in the descending part. We see forward flow in systole and holodiastolic flow reversal in diastole. This is 20 centimeters per second, so it makes it severe. Go into, sorry, excuse me, get ahead of myself. Deep transgastric view, look at the pressure half-time of the aortic regurgitation. It gives you a slope of 378 milliseconds, which is more than 200, would put it more in the moderate zone. So you always have to combine your measurements, don't just make your judgment on a single measurement. And this is a four-chamber view. So any concerns here? Quite a dilated RV. Let's put some color on. What's the cause of this dilated RV? Have a look at the bicaval view, and you see a significantly bowed out intra-atrial septum into the right atrium and a significant ASD. And that was actually visible on the first short axis view of the aortic valve I've shown you, and some of you might have picked that up. So this was a significant ASD, which also had to be closed. So the message from that is, do not always focus on your known lesion, but look at everything, do a complete study. Otherwise, you might miss things like that, and your surgeon won't thank you if you come off bypass and you suddenly say, really sorry, but there's a significant AVR, and we have to go back on bypass. It also affects the cannulation technique, so you need to know that early. This is post-repair. So what they did is just an interposition graft in the ascending aorta, and they left the native valve in situ, which looks okay here at the moment. But if you put color on, unfortunately there is some aortic regurgitation, but it is quite mild. So on balance, the decision was taken not to replace the valve because of the size of the LVOT. A new valve would have made the surgery much more complex by having to expand the sinus and also add to the operation time, and probably caused a very high gradient, being just a 19 millimeter valve. So going from bicuspid to the opposite, quadricuspid valves, quite rare, but they do happen. I've seen two so far. Usually central defect, quadrangular, with a central jet of aortic regurgitation. On long axis view, it can look a little bit odd. Sometimes you think, oh, there might be a dissection, but it's just the problem with having 4 leaflets in the LVT, in the ascending aorta rather than 3. As opposed to the rheumatic disease, if you have a severe calcific disease in a normal tricuspid valve, the problem lies more on the body of the leaflet. It becomes very thick and restricts the opening, becomes very stiff, where the rims of the edges of the leaflet quite often are quite normal. That's quite obviously restricted opening, the long axis view. A combined lesion, also with aortic regurgitation, which is a very common feature. It's very rarely just a pure aortic regurgitation. Central in short axis. And the last case, if you get to it, is AR with an aortic root aneurysm. So this patient had an enormously dilated aortic root, about 8 centimeters, which also involved the aortic valve annulus, stretching the valve open, so it had a central defect, couldn't coapt anymore, which caused severe aortic regurgitation. From the top, it looks like that. You can see the defect even in 2D in the short axis view extremely well. This is a two-chamber view, and you see how the regurgitation jet affects the mitral valve by bowing it into the left atrium. This is probably the mechanism that led to the perforation in the patient with endocarditis rather than an infection. Sorry. Our dimensions, so LVOT 3 centimeters, the aortic root 10 centimeters. The aneurysm was quite defined, so this is now the right pulmonary artery crossing the ascending aorta, and it's come down to 3 centimeters already, so it's quite a small, confined aneurysm just in the ascending aorta. The associated ventricle doesn't look too happy, quite dilated, significantly impaired function. Its end diastolic diameter is 10 centimeters. It's probably one of the biggest I've seen, and its ejection fraction is about 40%. Looking at the pressure half-time, this is now a transgastric long axis view rather than a deep transgastric view. You use a slight angle to the flow. We still get a good regurgitant envelope with a continuous wave Doppler, which gives us a pressure half-time of 209 milliseconds, which puts it just on the edge of severe to moderate MR. And I think I'll probably need to stop. Yeah, or shall I continue? Okay. Thanks a lot.